would first like to thank my co-authors, Dr. Demoli and Dr. Hogan, for the chance to present our case report entitled Revision Total Knee Arthroplasty for Chronic Histoplasma Capsulatum Prosthetic Joint Infection. As we all know, prosthetic joint infections, or PJIs, are a relatively common yet devastating complication following hip and knee arthroplasty procedures. The majority of these are bacterial and etiology, however a small percentage are caused by fungal pathogens. Fungal infections represent a particularly challenging clinical entity for several reasons. First, they are often indolent and more chronic in their presentation. Inflammatory labs and other laboratory values can be inconclusive or minimally elevated. Synovial analysis often requires prolonged incubation with selective media and can be further clouded by bacterial co-infection. All of these are a symptom of the patient population in which these most commonly occur, including those with multiple comorbidities and those on lifetime or chronic immunosuppression. As a consequence of their rarity, treatment strategies are less well defined and range from suppressive antifungals to 1- and 2-stage revision procedures. Therefore, the purpose of this case report was to describe the diagnosis and treatment of a Histoplasma Capsulatum PJI in a chronically immunosuppressed patient that was successfully treated with a 2-stage revision procedure and suppressive antifungal therapy. Our patient is a 54-year-old female with a past medical history of mixed connective tissue disease, including systemic sclerosis, rheumatoid arthritis, polymyositis, and Sjogren's disease that was being managed with prednisone, methotrexate, and IVIG. She had had a left total knee done approximately 18 months prior to presentation. She had had a chronically painful knee with multiple episodes of overlying cellulitis treated with oral antibiotics. She had had multiple prior joint aspirations, all of which were negative for cell count and synovial culture. On exam, the patient was tender and moderately erythematous overlying the patella. Radiographs obtained in clinic demonstrated a stable implant without evidence of loosening. Inflammatory markers, including C-reactive protein and ESR, were moderately elevated. Repeated synovial analysis was obtained, including both in-house and send-out for SynovaSure testing, which was positive for alpha-defensin, neutrophil elastase, and 3,400 nucleated cells, including 57% neutrophils. The microbial panel, including Staph, Candida, and Enterococcus, were all negative. Based on SynovaSure testing and minor criteria, the decision was made to proceed with elective 2-stage revision. Following a 6-week antibiotic holiday, the patient underwent stage 1, including explantation, antibiotic spacer, and placement of temporary components. X-rays in Figure 1 demonstrate anteroposterior and lateral views of the left knee obtained after explantation and placement of the articulating antibiotic spacer and temporary components. Cultures including synovium, synovial fluid, and tibial bone were all followed postoperatively. At 2 weeks postoperatively, 3 or 4 cultures were found to be positive for mold and were subsequently speciated to be morphologically consistent with histoplasma. Following this diagnosis, the patient was admitted and underwent a 2-week induction with amphotericin B, followed by an oral course of itraconazole. Repeat aspiration at 6 months was performed, demonstrating negative fungal growth in addition to other synovial analysis. At that time, it was deemed appropriate for the patient to undergo stage 2 revision, which included a hinged knee prosthesis, of which the components were cemented with both gentamicin and voriconazole cement. Postoperatively, the patient was placed on oral voriconazole with plans for long-term therapy. 7 weeks following stage 2 revision, she was seen in clinic and noted to have near symmetric range of motion from full extension to 125 degrees of flexion. She was able to ambulate without pain and was released without restrictions. At her most recent follow-up at 18 months, the patient was continuing to do well. However, she had experienced multiple lateral patellar dislocations. However, these were amenable to self-reduction and treatment with a patellar stabilizing brace. At this time, she is infection-free and remains on suppressive antifungal therapy. However, this has necessitated multiple changes in medication due to adverse reactions. At the most recent follow-up, she was tolerating treatment with isobuconazole without signs of systemic or local recurrence. In Figure 2, we see anteroposterior and lateral radiographs of the stage 2 construct, including the hinged knee prosthesis that was cemented with both antifungal and antibiotic cement. In conclusion, this case represents a prototypical fungal PJI patient, including one on multiple chronic immunosuppressive therapies. She presented with chronic and indolent symptoms, moderately elevated inflammatory markers, and repeatedly culture-negative synovial analysis. This emphasizes the need for a high degree of clinical suspicion in these patients. Finally, although treatment strategies for fungal PGIs are less well defined than bacterial infections, we believe that our prescribed treatment course, including two-stage revision with interval use of systemic antifungals, antifungal cement, and suppressive antifungals postoperatively, demonstrates the most viable course of treatment compared to alternatives, including suppressive antifungals alone or one-stage revision. Below is a list of selected references. Lastly, I would like to thank my co-authors and mentors, Dr. Demoli and Dr. Hogan, for the chance to present this case report, and thank you for listening.